So as I was saying, last but not least before the break, we are going to move from national registries to some of the closest ideas we have of this in the U.S., which are HMO-based research. And so I am really happy to introduce Dr. Lisa Croen, who is the director of autism research within the Kaiser Permanente research. The title of the actual, it's not Kaiser Permanente itself, but Research Institute. Division of Research, yes. And also a member of our scientific advisory board for the center and a longtime collaborator with folks in the room for sure. Welcome.
Thanks, Danny, and for the invitation to come talk about my work and doing work in the HMO setting, which is really a lot of fun. Okay, I have to figure out where's my controls.
The
just
arrows.
the down, the arrow. Okay, so so I'm going to try to reiterate some of the things that have come up from the previous speakers, which have been really fascinating, and I've gotten many ideas to take home and try in my setting. I want to give you an overview of what my setting is. It's the Kaiser Permanente Medical Care Program, and specifically in Northern California where I work, and then give some examples of epidemiologic research that we've done in this setting, and then also health services research. So Kaiser is it's a group practice prepaid integrated health program, which means that the patients, the insurance company, the doctors, and the hospitals and clinics are all integrated together, and members of this system have Kaiser insurance, Kaiser Healthcare insurance. The doctors are part of the Permanente Medical Group in Northern California, so it's one group of doctors and clinicians who provide all the care for the Kaiser patients in Kaiser hospitals and clinics, and linked together with an electronic medical record, which is very comprehensive with referrals that go electronically between specialists and generalists. And so if you go in and get your care in one clinic one day and another clinic another day, everything about your care and everybody you've seen is accessible to all of your providers there. So it's really fantastic in terms of, from a patient point of view, I happen to be a patient there, but also from a researcher point of view. In Northern California, we have about 3.5 million members of Kaiser Permanente, and there's about 800,000 children. So you can start thinking about the numbers that we have available to study, and it's really great. Provided again by the physicians at the hospitals, and the population is very representative of the areas that are served by Kaiser. So there's, depending on how you count, you can see the counties in this slide that are served by Kaiser, and it's about 30% of the population living in these geographic areas that are Kaiser members, and the membership by and large is very, very representative of the overall population here, with the exception of the very extremes of the income distribution, but everything in between we've captured. So it's an incredible opportunity to do research at a place like this. And the reason is it's this very integrated system, as I've alluded to. Research sort of sits at the center of this vast number of resources, which includes this very diverse membership. The care providers, including the clinicians, the laboratories, the pharmacies, and so on. We've got this medical record, electronic medical record, that tracks a patient for every encounter they have with the system. So, and our patients are often members of Kaiser for many, many, many years. In fact, we've got generations. I'm thinking about Diana's multi-generational study. We've got grandparents, parents, children, and maybe sometimes 4 generations who have been in this system, who are all linkable together, not as easily as we can do they can do in the Scandinavian countries, but with using clever linkage algorithms with linking to birth certificates and tracking mothers and babies and so on, we can come up with family linkages in this membership. And we also have built very large biospecimen repositories, which I'm going to talk a little bit about. So it's conducting research in this system where the researchers actually are all, we're like academic researchers, whereas we have to generate our own funding. Unfortunately, Kaiser does not fund us to do research, but they make it a little more accessible to do the research, because we can access our patient population. And if you like to collaborate the way I do, we have access to all these wonderful clinicians and other scientific experts who are within the system to collaborate with and to really inform the questions that we want to study. So what I've done in Northern California over the past 15 years or so is established a research program focused on autism spectrum disorders, and we have a very broad range of a very broad portfolio, actually, spanning everything from descriptive epidemiology to analytic epidemiology or causal epidemiology, looking for early biomarkers, identifying both genetic and environmental risk factors, and then moving into more of the health services realm, which is looking at developing and testing ways of screening for autism very early on, and screening for other developmental, just general childhood developmental screening, evaluating interventions and treatments for autism spectrum disorders, looking at better approaches to deliver care for people with autism, both children and adults. And as that last statement alludes to, we really take a life course approach. So we're very interested in from everything from conception and before, actually, all the way through the end of life. And again, I have the opportunity to address all these different kinds of questions because I'm in this kind of setting where people are getting their health care and across the lifespan. The other really fun part of my job is working with our community advisory board, and we decided very early on, many years ago, that our work would really be better informed if we included the population that we're studying and the population that is serving the population that we're studying, and all of us get together a couple times a year to talk about what are the relevant questions, what are the issues, what should we be researching, what hasn't been looked at yet, what are the issues facing the families affected by autism, and so on. So we've put together a very diverse community advisory board that meets twice a year as a group, and many times in between, either individually informing us. And this board is made up of parents of children, adolescents, and adults with autism. We have self-advocates on the committee, individuals with autism spectrum disorder, physicians, community activists, service providers outside of Kaiser, and people from the school district. And so we've tried, and researchers as well, in addition to my team, some other researchers. And many of the people on the committee wear several hats at once. So they're sort of looking at this issue from many different points of view. And so it's really informed the research that we do, and I like to say that the 2 days a year that we meet with this community advisory board are, I think, some of the two of my most favorite days of work in the year for me. So you might be thinking, well, Kaiser, yeah, it's big, and it's you said you've got everybody except the extreme ends of the income distribution, but really, how representative is it, and how generalizable are your findings based on that population? So I think, as we all know in this room, the prevalence of autism has been increasing, and the current estimates are about 1 in 68 kids has an autism spectrum disorder. Do we see the same thing within the Kaiser Northern California system? And in fact, we do. What we have about, this is based on our census that was done just this past June. We have about 12,500, 600 children below the age of 18 with an autism spectrum disorder in the current membership. And we have nearly 6,000 adults, and you can see the distributions by age group, and our prevalence is really pretty much dead on with what the national estimates are. So, in fact, if anything, they might be a little bit higher. But this just shows the prevalence across the age span, and you can see in the 5 to 9-year-olds, which is basically what the CDC figure was. The 1 in 68 was based on 8-year-olds across the country. 1 in 68, we're seeing about 1 in 53, so it's very, very close. And as you see, as the age goes up, the prevalence goes down. That's probably not the real prevalence. It's just the measured prevalence, and this is in the adult ages. I think we're just measuring the tip of or identifying the tip of the iceberg. So we know that there are many, many more adults who would meet a current definition for autism who haven't gotten that diagnosis. Maybe they never will, but I think some of these they'll be coming in to get assessed. So in terms of numbers and also in terms of the demographic characteristics and the major risk factors that have been identified, many of which the previous two speakers told you about, we see the exact same kinds of relationships in our population. So we feel it's not completely generalizable to the total population of autism in the country. Nobody has a population to study that resembles that, but it's a very, very good fairly good representative sample to then generalize our findings to the broader community. So now I'm going to talk about some specific studies that we've been able to do using this population, and some cross-sectional studies, case control studies, prospective cohort studies, and then talk about a biobanking effort that we're doing as well. So the first thing I wanted to tell you briefly about is the Mental Health Research Network project that was basically combining data across 5 different HMOs, 4 of which are Kaisers and 1 was Harvard Pilgrim, to establish sort of a virtual registry. It's not quite as big as what Diana just told you about, but within the United States and within these HMOs, a registry to do many different kinds of studies. And so what and we also wanted to use this platform to establish some baseline data about healthcare, what people are doing not only within the system, but what they're doing outside of the system. So what's not recorded in the electronic medical record. So we did a survey, and we also did a pilot study to begin creating a biorepository. So I just want to show you these data. This is one paper that recently came out that looked at, this was based on the survey that we did, and this included about 1,200 families who completed the survey across 4 of the 5 HMOs that participated in this autism registry. It was Kaiser Northwest, Kaiser Northern California, Kaiser Southern California, and Kaiser Georgia. And the demographic characteristics across these different Kaisers is very different. So, you know, in Georgia it's very much more heavily African American, and in Southern California very heavily Hispanic, in Northern California lots of Asian, and in the Northwest a lot of Native American, smaller numbers obviously, but you know, proportionately and much lower SES. So we sort of had a diversity geographically and in terms of SES characteristic and race ethnic characteristics. And we looked at this paper was based on the questions we asked about complementary and alternative medicine use for autism spectrum disorders. And what we found was this very large, 88% of the total population had ever used a CAM therapy, either a product or a provider or a practice. We sort of had these different bins of CAM that we looked at. And there were certain predictors of use that were pretty similar across the 4 sites that are listed here. And there was also some geographic difference in the types of CAM therapies and products that were used in let's say Northern California versus Georgia. So that was a pretty interesting paper to do. We also were able to look at prevalence trends. You can't do descriptive epidemiology of autism without looking at prevalence trends. And so we had the ability to look these are birth cohorts, or no, this is not a birth cohort. These are years and what the prevalence was in a certain age range, basically in all pediatric patients every year over from 1997 to 2010 across the 5 sites participating in the registry. And you can see the general trend was the same. There was some variability across the sites, but in general we were all tracking pretty much what's been reported. At the first part, 1997, the prevalence was 0.02%, and by the end in 2010 it was about 1%. So again, tracking the kinds of figures we see from the ATOM network, for example, across the United States. So another example of sort of cross-sectional or descriptive epi that we've done is again, as Diana said, you can't do this without looking at parental age. We published a paper based on about many dozens of thousands of people, I can't remember the exact number now, looking at older age, both mothers and fathers, and finding independent increased risk for autism associated both with older mother's age and also independently older father's age. And we also were able to look at the differences in age and so on too, not nearly with the power that the study that Diana talked about. We also did a case control study, and again, this is just using the data. This is not enrolling anybody, so we get ethical, the Institutional Review Board approval to use the data that are contained in the electronic medical record, and also we link to birth certificate and the Department of Developmental Services, which is the statewide service agency that provides services for people with autism and other developmental disabilities. But without contacting anybody and just using available data, we're able to do some very powerful epidemiologic studies on the cheap, so to speak. It's actually not that cheap, but it's much cheaper than doing something like SEED or early or some of these other big studies that Danny's going to talk about, where you have to enroll people, consent them, collect data, and analyze, and so on. And so we did a case control study called CHAPS that was based on kids born in 1995 to 1999, and we're able to look at medical record data and again link to birth certificate and DDS, and look at prenatal and perinatal and neonatal and early childhood factors that may be associated with autism. And so we've published a number of papers. But these are papers looking at kids, congenital anomalies, infection in the first 2 years of life, neonatal jaundice, and then even more papers looking at prenatal exposures, both procedures like ultrasound or ROGAM and then also looking at certain drugs that moms might take for different issues, looking at infection and autoimmune diseases. And the one that got quite a bit of attention was looking at antidepressant use during pregnancy and risk for autism. And so that study was really the first that I'm aware of that looked specifically at this question of SSRI use by moms during pregnancy and risk for autism. And what we found was a threefold increased risk, basically a twofold increased risk for autism associated with SSRI use anytime over the pregnancy period. But specifically, it looked like the first trimester or early pregnancy exposure conferred a high risk. And one of the difficulties with this study is teasing apart the contribution of the medication and the contribution of the disease that you're taking the medication for, the depression. So this is this confounding by indication, which is really difficult, thorny issue to deal with. And several other people in other settings and using other kinds of data sets have replicated this finding and sort of come down, on one side or the other of the debate. Well, is it the medication or is it the depression that the medication is being taken for? And I don't think, it's sort of, I think it's a little bit equivocal at this point. Depending on your reading of the data, you might side on one side or the other. But clearly more work needs to be done in this area, and something that we're hoping to address with some other study data that we're collaborating on with Danny and others with the SEED study, for example. So more news on that later. So here's some examples of prospective studies that we've done. So this is using, rather than taking the case control approach, this is taking the whole birth cohort over many, many years and looking at those who have, for example, kids born preterm and kids not born preterm, and looking at the outcome of, and to see is autism more common in those born preterm, for example, on the left-hand side, which and this figure I think matches really beautifully what Diana showed also in terms of preterm delivery, that the risk increases the more preterm a child is, the higher the risk is for having an autism outcome. And it's actually quite high for these very, very preterm, premature babies. And another study we did that was published just recently by my postdoctoral fellow, Dr. Husseini Zerbo, we looked at this interpregnancy interval, which has come up before as being associated with increased risk for autism as well as other adverse outcomes. And we also showed that kids born within 6 months kids conceived within 6 months of the birth of their older sibling have a 2 to 3-fold increased risk of being later diagnosed with autism. And that risk, it's really kids born conceived within 2 years or after 6 years of their older sibling's birth have this increased risk. And it's interesting, why could that be? In our data set, because we have this clinical EMR data, we were able to control for many factors that other studies haven't been able to look at and try to rule them out, and we couldn't find anything that could explain this away. So we were able to look, for example, at maternal weight gain during or weight and weight retention from the previous delivery to this new pregnancy, because we know from other data that maternal obesity and overweight has been linked to an increased risk for autism. We were able to look at things like diabetes and hypertension and the outcome of the first pregnancy, the first sibling, the older sibling, and how that might influence the second, and many factors. And so we were able to rule out a number of factors. We haven't been able to really identify the genesis of this result, so more work needs to be done here as well. Another thing, so now I'm going to turn to biobanking. So this is a relatively new effort funded by the Simons Foundation. They were very generous in funding us to create a biobank of 5,000 trios. So these are 5,000 families, one affected child, and both biologic parents, to collect a biospecimen and bank it for future research, and also team that with the comprehensive medical record data that we have on many times on all 3 family members. They don't all have to be Kaiser members, but the affected child has to be a Kaiser member. So we have all of their longitudinal medical record data, plus many of the parents will also be Kaiser members. Get a biosample, and also we're asking the families to complete 2 very short surveys. One is the SRS, the social responsiveness scale, which gives a dimensional report of sort of social impairment, and we're getting that on all 3 family members. And then also we ask them to fill out a brief family history questionnaire. And so they can donate a saliva sample or a blood sample. And again, they don't have to get out of their jammies to do this. If they choose saliva, we'll send them the kit, very much the same as the Spark study. And so we're just in the very beginning stages of recruiting for this. And it'll be complementary to, I think, the 50,000 person collection that Wendy talked about, and complementary to many other biobanking, the Simon Simplex collection. The unique thing about this resource is that it's set within, again, this healthcare system where we have very, very comprehensive clinical information and the ability to bring in other family members and to link to all different kinds of databases and to easily go back to these families and recruit them for more detailed and deep data collection for any kind of question we might want to ask. And really, hopefully, with the discoveries we make in the genetics realm, match that with the clinical data and the environmental data, and translate these findings directly back into care and treatment for these families. So that's the really exciting thing about this. We'll be collecting information or recruiting over the next 3 years, and again, I said our target is 5,000 trios, and all of the data will be publicly available. They'll go into the Simons resource. They'll also go into the NDAR. So there'll be different NIH repositories that the data, phenotypic data, and ultimately when we have the genetic data go into for researchers around the world to use. Okay, so I don't want to give short shrift to the health services research. So we've done a number of things. One area that we've been very interested in is looking at adults. And again, we have this very large population of adults, and we wanted to know, firstly, what's happening with these adults. And we know that kids have many different medical issues associated with them. Do we see the same things in adults? And we know that children with autism grow up to become adults with autism. So let's look in our system again, sort of in a cross-sectional way, what we see. And so we published a paper on this recently, looking at the health status of adults. And also, as a companion piece to this study, we wanted to know what the adult medical care providers know about autism, again, in our system. Because, the kids are coming to them, and are they prepared? Do they know what autism is? And are they aware of the medical issues that are facing their patients? So in terms of the health care, or the health status, we found really striking increases in rates of just about every single medical issue and psychiatric issue in the adults with autism compared to adults without autism in our system, and they were very well matched by by gender and all that, so we could, and age, and so we could really they should be equal. They all should have equal access. They all have the same insurance and so on. So there's a big issue here with the adults, just as with the children, and the healthcare system needs to be informed, and the social service system, and education, employment, and so on, to deal with adults properly, adults on the spectrum. In terms of what the healthcare providers know about autism, this was also sort of kind of predictable, but also very disturbing. So what we found, we surveyed about 925 providers answered our survey. It was about a 25% response rate. And we surveyed providers in medicine, in OBGYN, and in mental health, in our system. And when we asked, how would you rate your knowledge or skills in providing care to adults with autism, you can see very few, less than 10%, said very good to excellent. And so, and 30 to 50% said poor. They gave themselves the worst rating. So this was one indication that things aren't going as well as they might. And then we asked, one of the other questions we asked was, do you have adequate tools or referral resources or practice models to accommodate people with autism in your practice? And again, only 20% or less agreed with that statement. So, and there were a number of other questions we asked, all indicating that they were, yes, they knew what autism was, but many didn't realize, think of it as an adult condition, number one, and were kind of clueless and felt very ill-prepared to provide adequate health care to that patient population. And one of the things that came out of this study was we followed up the survey with some qualitative interviews with about a dozen of these providers, just to begin to scratch the surface about what, to delve deeper into some of their survey responses and to try to get a bigger picture of what was going on. And the issue that consistently came up was this issue of transition, and the issue of transitioning kids from pediatrics to adult care. And so we decided to write a grant and got some funding from both the Special Hope Foundation and Autism Speaks combined to do a small pilot project looking at this transition from pediatric to adult medicine. And we're basically trying to describe what's happening in terms of the health status of this transition age group. And then we've got a big qualitative piece conducting interviews, not only with the transition age youth with autism, but their caregivers and their clinical providers, both on the pediatric side and on the adult side, and case management, so that we can try to get a 360-degree view of what's happening around this transition. And then based on the information from the first two parts of the study, we'd like to design some specific tools or resources that will aid this transition, and then actually put them in place and pilot test them in our system. So it's a really exciting project, and we're teaming with the Got Transitions people are giving us some advice. This is a group that funded nationally, part of MCHB, and working. We have a young adult clinical group of champions in our system that are dealing with transition issues in diabetes and ADHD, but and some other outcomes. But they're very interested in the autism population, and so we can team with them. And so finally, The last thing I wanted to touch on briefly in terms of health services is an evaluation of ABA. And what we're doing here, I think as many people know, there's been autism insurance reform that swept the country, and now as of 2 days ago when I put this slide together, 42 states had enacted legislation that requires the health insurance companies to basically pay for the behavioral health interventions. In California, there's no age limit, so it's just the law says behavioral health treatment for pervasive developmental disorder or autism, and so that has shifted the cost from the education system and where all of this is dealt with, from the education system in California to the healthcare system, and so we have a perfect opportunity to study. So now, with I showed you the thousands and thousands of kids that we have in our system who are all basically could all request, if they wanted to, behavioral interventions, and many of them would receive them. The health insurance company, Kaiser, has to pay for this. We don't provide we don't have these kinds of clinical experts. And so we're contracting with vendors like Easter Seals and others throughout our region to provide this care. It's everything has moved so quickly that we have all these kids we're sending to treatment without any kind of systematic way of monitoring what's happening, looking at outcomes, which kids should be sent to which kind of treatment, and so on. It's sort of it's a good thing on the one hand that it's available, and it's really horrible on the other hand because nobody really knows what works and what works for which kids. The system is spending oodles of money, and we, there's a diversity of patients, different ages, different kinds of characteristics, behavioral issues, and so on, and we really don't know what is working for which kids, and so we're doing a study that's the very first step. Again, it's a very small study, but trying to get a handle on this. And it's, again, a mixed method study, doing both quantitative look at what we can get out of our medical records, and then interviewing both the people who are providing the behavioral intervention and the Kaiser, on the outside of Kaiser, and on inside Kaiser, the clinicians who are referring to behavioral intervention and the case managers who are working with these families, and also the parents themselves to see what's happening, and then and trying to identify some specific factors that predict a good outcome. But what we've discovered in this process is there's no standardized way of measuring outcome, I think, in general, and specifically in our system, there's no standard metrics that are being applied. And so we've had to step back from actually doing a study looking at what predicts outcome to putting in place a system to capture information to be able to, in the future, then do the study to see what predicts the outcome. And so again, it's an opportunity to translate, sort of as a researcher, to get in there and make things move in a way that will set us up as researchers in the future to answer some questions that are incredibly important, just from a research point of view, important to families, and ultimately important to the service providers, so they can do a better job of providing the kind of care that is going to make the most difference to the families that we're trying to serve. So I've already sort of touched on that. So in summary, I think Kaiser and places like it are really incredible opportunities, and provide unique opportunities to do this kind of public health research in autism. It's this integrated setting with this huge population, very diverse in many ways. Lots of different resources, data resources, biospecimen resources, patient resources, and clinical resources to bring together. And generally the results are generalizable, and it's a really great opportunity for translating our research finding into sort of this bench to bedside kind of approach. So with that, I thank you for your attention.
Questions?
David?
It's really cool what you can do in your system and with your data. I was really struck by your 1 in 53 finding, because in the CDC sites,
Mm-hmm.
the the 1 in 68 includes 20% of kids who didn't have an autism diagnosis in their records, and usually the observed prevalence is lower in sites that only had access to healthcare records and didn't have access to education data. And so I'm wondering what's going on in Kaiser that you're only looking at healthcare records and you have a prevalence that's really, when you compare 20% less, so 1 in 185 versus 1 in 53, that's really a substantial difference. And so do you think it's something about your system, about diagnostic practices, about what the service environment in California is like? And how much then do you believe all of that 1 in 53?
Oh, okay. So in terms of the validity of the diagnosis, so in Kaiser Northern California, we have, since 2004, we've had specialty clinics that all they do is autism evaluations. They're sub-regional centers, and now there's 3 across the region of Kaiser Northern California. So there's 1 in the South Bay, 1 in San Francisco, and 1 in Sacramento. So it kind of covers the geographically. And those clinicians are, now those centers are diagnosing, everybody who gets a diagnosis of autism in Kaiser is either seen directly by one of those centers or their records are reviewed by the clinicians at those centers. And those clinicians have become experts, they're Ph.D. level psychologists and psychiatrists and developmental pediatricians. It's a whole multidisciplinary team. And so I believe those diagnoses are very valid. They use the ADOS and then a number of cognitive things. So I think what's happening is that we can capture everybody, number one. I mean, we can, every kid who's in Kaiser, we know if they've gone to one of these centers, we know if they've gotten a diagnosis. And we've done different validation studies to bring in and say, okay, everybody with this diagnosis, is it real? And we've done it different ways, both by bringing kids in kids who have participated in studies like SEED and early, where we actually do a gold standard, research gold standard assessment, or doing medical record reviews where we do more like the ADAM approach, where we review the records. And we can validate, just not 100%, but almost all of those diagnoses. The other thing is the geographic area. So, we've got Silicon Valley, we've got a real concentration of medical expertise in the San Francisco area, the Sacramento area, and the peninsula, who are aware of autism. And so I think we're just doing a better job of capturing it. I don't think it's inflated. I think we're actually doing a better job of counting all of the children who are in this area. And there might be some, there may be some demographic differences too. I mean, there are older parents but that's not going to explain too much of that. So I think, it's just, it's a pretty population-based, of the, those 30% who are covered by Kaiser, I think it's pretty representative of what is out there in general. Yeah.
Just to follow up on that. 10 years ago,
Mm-hmm.
looking at the this factor in terms of diagnosing, were those teams available 10 years ago? 15 years ago?
The team.
Question first.
Yeah. Okay. So he's asking, were those clinical teams available 10 or 15 years ago? So the first clinic opened in 2004, and then the second in 2006 or something, or 8, and around there. So the numbers have gone up. Our numbers have gone up, and our diagnostic centers have increased. The numbers of our diagnostic centers have increased, but there's definitely greater awareness, in the general public about autism, and I think also within Kaiser, because all of the pediatricians now have been trained. Look, if you're worried, refer to these centers, and we also have, over the last 3 or 4 years, have had a very organized early developmental screening program that is actually, this month, has just become universal screening for autism in 18 and 24 months. But before that, it was sort of red flags, you would get screened. So all of those factors, I think, really help to identify the kids who are out there. So I think it's a pretty accurate number. I don't think we're over-calling it. And I've talked to many clinicians, and they said, no, if anything, we're still missing people. especially at the older ages. Yeah. So, not the young ones. The little ones, I think we're getting all of them. Yeah.
Couple of questions. I think there's like 6 main regions of Kaiser, and like we're in the Mid-Atlantic states here. Do they have the same type of autism centers that are here?
No.
As you do, or is it exclusive in Kaiser to California? where
So,
you are?
yeah, so the question is about the Kaiser. So there's actually 7 different regions, and do each of the Kaiser regions across the country have the same kind of diagnostic evaluation centers? And no, Kaiser, the CEO of Kaiser likes to say it's one Kaiser, but actually it's that's not the case. Every region really operates independently, and each facility within each region sort of often operates independently, or not completely independently, but they have their own ways of doing things. So in Northern California, where we have these 3, we're the most sort of organized in terms of autism evaluation. It's done differently across different regions, and I think in the Mid-Atlantic region, even the hospitals are not necessarily owned by Kaiser, and I mean, there's sort of a different practice model than it's not as completely integrated as it is in Northern California. So there's a lot of variability.
And my second question was, since you own this data, do you need IRB approval every time that you do the?
Oh, yeah, so do I need to get IRB approval every time I want to do a research study? Absolutely. We're governed, and it would be the same, if you wanted to access the data, it would be the same thing. You'd have to go through this, I have to go through the same IRB process as an outsider. Yeah, it's very highly guarded, and all of the ethical approvals are in place. We're very much like academic researchers, even though our office is in a Kaiser building. Everything else about it is we don't really have, we know more about the data obviously because we're in the system and we have better access. We're all in the same email system, so I can easily identify and email the chief of OBGYN if I want to and start a relationship. But in terms of a privilege, it's very much, the patient data are guarded as they should be, and there's all the things in place to make sure the data aren't over abused and PHI is not given out and so on. Yeah.
Sorry, when you look, do you have enough people diagnosed with anxiety? Back to the maternal depression in SSRI study. Do you have enough women diagnosed with anxiety who are also on SSRIs that would enable you to compare them to women diagnosed with depression on SSRIs?
Yeah, that's a good question. I don't know the numbers, that would be an interesting thing to do. You'd still have this indication versus treatment issue. It's not depression, it would be anxiety. But that would be a very, so in other words, if I get where you're going with this, if we saw something, an association with SSRIs for women who are being treated for anxiety, and then we saw the same thing for women who are being treated with SSRIs for depression, you still have this confounding by indication issue. But maybe that
of the interaction of diagnosis and SSRI. Of course, community diagnostic practices are not great, and who knows what the etiological relationship between anxiety and depression are. But for example, if you saw the effect, if you saw the effect in women, SSRIs increase your risk more than just having depression in your study, but that could be a severity issue. I wonder if you see the same, pattern in anxiety, if the anxiety and the depression are etiologically unlinked, or if they have different etiologies or different mechanism, then it might throw weight behind it being the depression per se or the SSRI.
SSRI, yeah, that's a good point. I don't know are there any psychiatrists in the room? I'm not sure what proportion of how much people with anxiety without depression are treated with SSRIs. I'm not sure, but we have large numbers. What I'd like to do, is look at women with depression who are being treated with SSRIs, and a comparison group of women with depression who were never treated with SSRIs, and then women without depression and without treatment. again, you're still going to have an issue because those who are those people with depression are not equal. There's some reason why some got treatment and some didn't, treatment with SSRIs, but it gets a little bit closer to being able to tease those two things apart. But I'll look at that. That's an interesting idea. Yeah. Thanks.
Well, thank you to
Okay.
Dr. Croen.
Thank you.